you have to be able to look your staff in the eye and tell them that AI will not replace them.
I sometimes encounter kind of an underlying fear, maybe a perceived threat to our livelihood.
Bill Franz and Andrew Jahnke are the specialists transforming broken healthcare workflows into high-margin, AI-driven engines.
We're a small, I like to call it boutique consulting firm that's made up of folks like you from health centers and safety net providers. So we all have leadership experience in those areas.
How do you ensure that centers remain compliant, particularly around patient privacy?
If they don't know what HIPAA is, FTCA and all these other regulatory requirements are in the healthcare space, then they're entirely likely to walk a health center maybe down the wrong path.
What are some of what you would consider the most common kind of daily administrative burdens for staff, and where do you most often see productivity being lost?
Everything from call center activities to call center agents repetitively putting in the same information over and over. That could be automated.
Is it possible to get a custom solution that would work for multiple health centers?
This is sort of one of these super powerful levers that, again, are available in nonprofit health that don't really exist out in the so-called business world. It's absolutely like every other type of technology. There's real code, there's information in, there's information out. You just have to understand it and learn it, and then
Let's get started. Bill, Andrew, would you please introduce yourselves?
Yeah, welcome everyone. I'm Bill Franz. I'm president of Thrive. We're a small, I like to call it boutique consulting firm that's made up of folks like you from health centers and safety net providers. So we all have leadership experience in those areas. We help health centers in the areas of finance, operations. We have clinical staff, and we strive to improve the performance and the efficiency of health centers. Andrew?
Thanks, Bill. Yep, my name is Andrew Jahnke. I'm the founder and CEO at RainTech, and we are a healthcare-focused, AI-forward, fully and co-managed IT service provider. And so our roots are in cybersecurity and compliance, and that's what we've typically helped health centers with. And now, of course, with the advent of AI, we've begun developing custom AI projects for health centers as well.
Thank you. I'm Lesa Peterson, former FQHC executive. I worked with Bill for years, in fact. I am currently with Element One Consulting, and I will be moderating today's session on how AI can reduce administrative burden while strengthening revenue and financial stability for community health centers. AI is rapidly becoming one of the most powerful levers for stabilizing health center finances. In this co-led session, Thrive and RainTech will jointly illustrate uses of AI that reduce burden and increase revenue, with examples from call center automation, better claims management, denial reduction, improved credentialing workflows, overall administrative task relief. They will show how to frame AI as both a workforce uplift engine and a margin preservation tool, hopefully freeing staff from all of that repetitive work, enabling them to do higher value tasks, and ultimately protecting organizational sustainability. So to start off, let's just address the elephant in the room. As someone who works with health centers on compensation programs, I sometimes encounter kind of an underlying fear, maybe a perceived threat to our livelihood when you talk about someone's compensation, or especially AI, a fear of being replaced by AI. So my first question would be, how do you address that trepidation that employees might feel when they're being asked to adopt AI initiatives and revamp and change their workflows? Tell me about that.
Well, that's a great question, Lisa, and I think it's always a great point to start out at. We've got to get through the hype cycle. We've got to get a little bit deeper than the narrative that we're all seeing in the headlines, because the headlines have to do with facets of this technology that don't really apply here. And I would say the first and foremost one that drives adoption is in the for-profit realm, that this is exactly what executives do, is they try to find disruptive technologies and then say, hey, how can we reduce headcount? And so that narrative is being spread pretty far and wide, and it simply doesn't apply here. It certainly doesn't apply in nonprofit health. It doesn't apply here at RainTech. It doesn't apply in the places where real AI adoption is happening and where real efficiency gains are happening. And that's because you just absolutely have to face that first question head on, and you have to be able to look your staff in the eye and tell them that AI will not replace them. And it stands to change their job quite a bit and make things more efficient, and hopefully allow them a lot more time to do more patient-focused activities and to do more high-value work and less repetitive work. AI cannot replace humans, and we're going to dive a little bit into some of the examples today and see what it can do and what it's not going to do, and what humans are still going to be needed for doing in these. And again, they're more high-value work, but we have to address this each time head on, because until people realize that this is a game changer that works for them and allows them to do less of that tedious and meticulous and repetitive work, they're not going to drive that adoption. And these are the users that do have to be focused on how it works and whether or not it's working effectively in order for it to work at all.
And folks that I encounter at health centers, when the topic of AI comes up, a lot of them just don't understand that you're in control. You're going to set the guardrails. You're going to have the policies. And that's where you start. As you gain an understanding, you develop a human statement. What does AI mean to my employees, to my patients? What are our goals? And move forward with setting up the parameters, the guidelines from that. And I think that's an important step for folks to understand. In order to implement AI, you have to understand that you're still in control.
So Bill, then what are some of what you would consider the most common kind of daily administrative burdens for staff, and where do you most often see productivity being lost?
Everything from call center activities to repetitive, call center agents repetitively putting in the same information over and over. That could be automated. Eliminating billing and coding errors before those claims go out. Efficiencies in registration, and especially in credentialing. That's an important area. A lot of the credentialing process, and we'll get into that a little bit later, a lot of the credentialing process can leverage AI.
Okay. Yeah, I know there's a lot of risk of human error in overly manual processes, so I think there's an opportunity there for sure. So Andrew, when organizations like health centers reach out to you, what types of workflow pain points are they talking about, or what are the things that they want to solve first when they reach out to you?
It really seems like patient engagement, sort of on front-end communications and interactions with the patient, along with revenue cycle management, seem to drive a lot of these conversations. And to the point sort of this session specifically, these help drive revenue and to preserve margin. And so it makes sense that these are the higher value targets. Now, that's not to say that there aren't dozens or maybe even hundreds of additional workflows that can support people that are in finance and supply chain and things like that. But I would say that upfront, engaging with patients and making sure that we are optimizing the chances of a really high quality encounter when the patient comes in, and optimizing the chances that they're going to come in, and reducing no-shows, and combined with all the components of revenue cycle management seem to be top of mind.
Okay, well, obviously it's the start of the revenue cycle, so let's start at the front door. So how is AI supporting call centers and specifically intake workflows?
Bill, you've actually worked a little bit on call center setups before,
Yes.
and I think this is a great opportunity for you to talk about kind of what that has looked like traditionally, and then we can talk about what how we adapt those previous models using AI.
Well, first I should correct myself and not call it a call center. As Lesa and I developed at our health center, it's patient navigation, right? It's allowing that patient to have an experience like they're talking to the person at the front end in an office. As far as leveraging AI in the call center environment, what I see is the system, AI recognizing the phone number, prompting and pre-filling information for an appointment, giving the patient navigator the opportunity to have a more pleasant conversation instead of doing a lot of pointing and clicking in the EMR or the practice management system.
Yeah, it can certainly perform those functions much more quickly than a human being. So if a patient's sitting on a phone and a human being's having to ask all these questions and then they're entering them all in, it's going to save time. And I think as we look at this first example, and I'm going to bring this up sort of time and again, we really want to look at both halves of the coin and make sure that we are showing and exemplifying how AI is an amplifier and not a replacement. And so for low-hanging fruit, for simply schedule requests and things like that, AI is perfectly suited for that. And it can work in multi-language and be adaptive to who that patient is and what their requirements are. But there is always the escape hatch, as you might see it called sometimes, where if that patient has an outlier case or there's something that is not otherwise anticipated within the workflow of that AI workflow, then it needs to be able to immediately escalate to a human and seamlessly, so that AI agent can say, oh, I see that you're asking about X, Y, or Z. I'm going to get you over to a specialist or somebody that can help you with that, and they go straight to the human. And so we're not eliminating in any stretch the interaction between patients and human beings. We're optimizing that and making sure that those humans who are available for those patients can be there for those edge cases and to help that patient navigate that process that the AI that might be designed to handle 90 or 95% of use cases isn't able to handle.
And one of the things that we really have constantly focused on is we want to increase face time, not just for the clinical provider, which we'll get into in a future session, but every step of the way. We want those conversations and interactions person to person, from patient to front end staff or patient navigator, to be the most productive and most meaningful to the patient.
Okay, yeah, presumably if you're reducing wait times and handling the volumes better, it would have a pretty positive impact on staff day to day. To your point, have a little more face time with the client versus just trying to field a phone ringing off the hook. Okay, I appreciate that. How about, beyond intake, how about credentialing? I know that can be a big issue. Provider credentialing in particular can be a pretty big bottleneck for revenue. How do you see AI streamlining credentialing workflows, Andrew?
Sure, absolutely. Well, again, I'm gonna put this in the context of the things that it's likely to do very well. As well as cover the things that represent edge cases where it may not. If we can pull up the credentialing slide, so you'll see major value, intake and completeness. So collecting the provider information from all the databases where it's available, flagging those missing items. These are things that AI workflows are just absolutely ideal for, because it's repetitive over and over again, and the data sources are similar and standardized. You've got monitoring, so retrieving this information and then tracking expirations and maintaining a real-time credentialing picture, so that as licensing and other requirements come up over time, that this agentic workflow is automatically surfacing those. So it can automate enrollment, so any time that we have an API or an application programming interface, that allows AI to submit information directly to any number of other platforms and software vendors. So obviously committee prep and compiling all this information into a usable form for humans to actually start to review it, and then again do this ongoing compliance monitoring, which we also talk about in governance, risk, and compliance applications as well. And then again, where they're not going to and where we need human judgment are going to be these edge cases around things like malpractice and complex histories, and it might have former military service and other things that need to be factored in, or it might have holes in past performance and employment history, and those things need to be still filled in and ultimately understood by a human being that understands what the credentialing process is really for. And so it's both sides of that. And so this can, again, excel at reducing the manual workload and the really repetitive tasks to make sure that those humans are available for those edge cases and those things that require a bit more of that deeper research.
And when you accelerate your onboarding, of course, you're getting your revenue faster, but you also stabilize and reduce coverage gaps, makes scheduling easier. It relieves pressure on clinicians. A lot of times in health centers, I've seen, well, this provider isn't credentialed with a certain payer, and they're trying to adjust the schedule, which makes scheduling difficult. So the faster credentialing basically means fewer locums, less overtime, and better access, which is what we're really here for, right? Better access for the patient. And these directly affect both staff and patient continuity.
Yeah, I've been a party to that, trying to schedule providers when they're only credentialed with certain plans and how difficult that can be, and then end up doing it wrong and providers seeing patients that we can't get paid for. So faster credentialing, I think, would be very welcomed. So beyond intake and credentialing, where else do you see AI removing some of those more repetitive administrative burdens for teams?
Well, we can talk a little bit about reducing denials, because that dovetails really well in with credentialing. And that's one of the things that can be checked ahead of time, and whether or not that physician is fully credentialed, whether or not the patient is fully pre-authorized for the care that they're going to receive. All of these checks can be done ahead of time automatically before we even start an encounter that may not lead to a fully reimbursed event for the provider and for the health center. And so we want to make sure that the all those checks are being done ahead of time. So the insurance eligibility verification and prior authorizations and all of these things, so that when that patient comes in, that the physician that they're going to see is fully credentialed for the payer that is going to be reimbursing for that encounter. And so that making sure that all these things line up before that claim is ever even submitted to the payer. We've been sort of pre-checking and pre-building the case for that encounter for just that payer specifically.
And I think what is very important too is when tasks are automated, you normalize and standardize your data. And it allows for better reporting, more accuracy in your records. And that normalization of data, I think, is very important, because I can't speak for everybody, but I've seen a lot of health centers that struggle with their reporting because data isn't being structured the same way by the provider or the employee.
Yeah, and I think optimizing it ahead of time pre-claim is what also helps in your post-claim and denials. And when you do need to make a case back to that payer, now you've reduced the overall number of encounters and claims, first of all, that even need to be reviewed manually. And then you can start to build on and train that workflow around additional rules. And so as you see that, you'll start to see patterns emerge, because this one payer always tends to deny claims that are around this particular diagnostic or this particular procedure code, or maybe this particular provider. And so when those patterns start to emerge, again, we get into the second half where then the human being has to look at that and say, like, hey, what's really going on here? Is there something that we can improve with staff training, or is there a new rule set that we can introduce to that claim submission process to optimize that even better? And so then you get into things like code scrubbing and optimizing claims before they get submitted, to make sure that as we see those patterns emerge, then we can start to commit new rules to that process to say, hey, every time Dr. So-and-so performs procedure such and such, then we end up with this claim getting denied. And so we can start to scrub for that and optimize that submission before it gets sent, to make sure that that payer is getting what they need from that provider, to make sure that that claim gets reimbursed correctly.
Okay, so like one of my frustrations with eligibility has been, like, I'm told that a lot of times the EMR will go and it'll check the portals, but it doesn't always do it effectively. And it especially doesn't do it with dental claims. And so you're pretty much, I mean, you're assuring me that AI can kind of set that up such that the portals get checked and you can actually check that eligibility more robustly than our EMRs do. That's a personal frustration.
For sure. No, that's a great question. It's a great way to ask it. So better than the EMR, perhaps, and for a particular reason. It's not that the EMR isn't designed well and doesn't have the capability of doing this. It's because when we get into what they might want to call edge cases for them because it's a relatively small percentage, and primary care might represent a much larger, and particularly in fully qualified health centers, a much larger percentage of what those where those reimbursements are coming from. And so there are a lot of state level Medicaid programs, for example, where eligibility verification is not currently available through the EMR because their application has to be customized for 50 states to go check all of those. And there isn't even just one per state, and different states do them differently. And so then you've got behavioral health and dental. And so there's just a lot for them to go and do. And, I'm not, playing the world's smallest violin for the EMR vendors. They're obviously choosing which features to bake in based on all the users of their platforms, which of course are not just FQHCs. And so it's important to realize that functions that might be around reimbursements associated with lower income populations may or may not be making it up to the level of priority that we would like it to, just based on the number of health centers, the number of users that are asking for those features, and then the number of times that that's got to be specialized. So we're basically complete today and about to go into beta testing with a health center in Virginia, where we've designed an agentic workflow to do exactly this, that addresses very specific state level and nuanced sort of additional checks that weren't being verified by the EMR. And so users were having to go and log into a variety of different websites to find this information and ultimately verify eligibility. And so in our pre-demo so far that they saw, it looked very promising. They said, yes, this looks like it's going to do sort of what it was that they were asking. We have a few more things in there we think that they're also going to find very helpful and time-saving. And so we look forward to seeing how that goes over the next few weeks once we get them in and start beta testing. But we've got some baselines for how much time they're spending doing this now, which is somewhere around 100 hours or so per month doing this. And so our team is excited, frankly, to see how much time we're saving them. We've obviously done these internally ourselves, and our teams are just over the moon. And so when we talk about, people having concerns over, job security and all that, it's like, imagine the total opposite end of that spectrum, where people are now just like breathing big sighs of release and just going like, gosh, look how much more efficient this is, and look how much time that this is going to save this person and allow them to do any number of other higher value tasks, frankly.
Yeah, and that's really what you want, is you want your employees doing the highest value task and operating at the top of their scope. How many times do we hear, oh, this is the manual workaround? I hear that all the time. Well,
particularly when it's something other than primary care, like you said, with dental or behavioral health, because we focus on primary care. Yeah, absolutely.
Oh, there's a saying in IT, actually, there's nothing more permanent than a temporary workaround.
Yeah. But that's where AI can take a manual workaround into a process, a systematic process.
Yeah, and give that user one single interface to go access any number of these other, again, kind of one-off portals and data sources that don't exist within the EMR today. So that's one example, and a place where AI can really help fill the void, because again, it's not that the EMR companies don't write stable software that knows how to go out and do the things that it's doing. Does it always do it to the same quality? Does do some of the billing components and back-end RCM functions always operate the way that health centers are maybe sold on? That's a question for Bill, I think, to touch on a little bit more than me. But on that front end, absolutely, we can save a ton of time.
Well, I don't think I've worked with a single health center that didn't say, well, the EMR doesn't do this and we need it to. And if you can bring that process and automate it through AI outside of the EMR and then push it back into the EMR, you can customize essentially your EMR to your particular needs, service lines, etc.
That's right. And that's really the future of what enterprise level AI development and solutions look like. Again, when we talk about cutting through the hype cycle, the headlines, we're not talking chatbots. We're not talking Goldman Sachs. We're not talking about Anthropic versus OpenAI and Google and coding assistants even. Those are all very interesting conversations. There's certainly a place for them to be had. That's not what we're talking about here. We're talking about very bespoke custom solutions that have very narrow but very powerful AI-driven capabilities, where we can ingest information from a variety of different places and then in a standardized way make sure that all that data is normalized and goes right back into the application where it really needs to be. So it's really working hand in glove, and we're eliminating additional screens and websites and platforms that people need to go to by having these workflows integrate so tightly with what's already in place.
And I'm assuming those real-time insights are going to be a lot more helpful when trying to manage your finances. I mean, Bill, how important, I know when you go into centers and do assessments, in terms of having that real-time insight to actually for smarter reporting and forecasting, and what, tell me about that.
Well, the first thing is, if your data is more standardized, you can have that real-time reporting. You need to identify an issue or when something's going off the rails as soon as it happens. And what you sometimes find is, for instance, we have a provider not closing charts, or we have some type of coding issue. Well, a weekly report comes out, somebody gets it on Friday, they look at it on Tuesday, then they go and try to correct the issue when you're already lost that week and a half. By setting up that real-time reporting and even real-time alerts with certain concerns that you might have, you're able to identify and correct issues immediately, as opposed to doing a weekly or monthly or a quarterly reporting cycle. You don't want to say, hey, at our quarterly meeting, we've identified for the past quarter, we've had this particular issue that's affecting our revenue. We want to identify it today.
Okay, so then let's talk about, in terms of these real world issues, ROI. So if an organization is choosing to adopt some sort of AI in a particular problem or issue, what does a realistic timeline look like? When can they expect to see something meaningful happen when they make this investment of time and resource?
I think sooner than they do with traditional platforms, for sure. One, an EMR or a platform of that size and complexity, like an ERP or other complex platform, takes a long time to take root, because every department has an entire onboarding process and training process and all of that. And so, again, when we get down to very bespoke and custom solutions that are designed literally for as little as one person, and that's what I'm saying is so powerful here, that we can design this process that maybe at this one health center only one person is doing. But if we can save them 100 hours a month, now they've got these other requirements that they would love for that person to be able to go and spend their time on. But that's not just where we stop, because now we've built a solution that uses a whole variety of, say, one-off or nuanced mechanisms that are in one particular state, for example. Well, we've got, in the case of Virginia, 31 health centers in Virginia that all happen to use the same EMR. And so now we can multiply that across the board. And again, these are levers that don't exist really in the for-profit world, because effectively these are people who compete with each other, and they're not really crowdsourcing information the way that FQHCs do. And FQHCs lean heavily on their community and on each other to say, hey, what's working, what's been working. And so that's why there's so much more opportunity, frankly, in the nonprofit healthcare space to drive real, meaningful AI adoption, because they're already understaffed. And so there's plenty of activities and things that they would rather people be spending their time with, and then they can share and leverage these levers that they develop across the board. There's 1,400 health centers in the country, and every single one of them stands to gain by sharing the information and sharing the solution and sharing how these things work. So it can be much faster. And with the example that I told you, I think we started brand new, basically starting the first line of code written for this literally about 2 months ago. And so I think that 2 months in the grand scale of things, when you're talking about a net brand new solution that's written, effectively from scratch, 2 months is actually pretty short. And so their ROI is going to begin nearly immediately. So again, we need to reach out to them. We need to schedule the beta testing to start hopefully a little bit later this week. And within, a week or two after that, we're hoping to have collected new baseline statistics on how much time they're spending on it. And so so the question of ROI, I think, is both a question of timing, but it's also a question of what your KPIs are. So again, in Wall Street, they're going to send somebody down the hall and say, eliminate 5,000 jobs. And KPI to them is sort of like what goes net to the bottom line. And that's the only thing effectively that they're looking at. But in our case, we really need to focus more on time savings and how much staff time is freed up to do other high value work, and then go another layer beyond that. So we talked about patient engagement. We were really only talking about phone-based engagement, but you can also have, a chat-based health assistant that's helping you schedule your appointments and follow up on, recommendations or dietary nutrition recommendations that were coming from doctors afterwards, and really helping to keep that patient engaged. And so we have to look at additional KPIs, which again, health centers are so good at looking at what drives outcomes and what's increasing patient engagement, what's decreasing no-shows, all those things. I think that we can look at and have a pretty direct correlation between the AI and agentic, as we call them, but agentic workflows. So these individual AI solutions doing this, we can see in real time. Once we get them deployed, we can start to look at these KPIs that health centers are already collecting.
Okay, but then with all of that, compliance always comes up. How do you ensure that centers remain compliant, particularly around patient privacy? Obviously, you have to continue, I assume, to have human oversight when integrating these tools, but I know that patient privacy and compliance is huge for health centers, and anything new is kind of scary, I think, in that regard, because you don't want to risk that.
Well, I'm going to start by saying you need the right vendor, and you need somebody that has experience in healthcare, has the right certifications. That's actually one of the things that brought me to RainTech. When I was introduced to Andrew and got to know him and his team, they know HIPAA, they know healthcare, they're HIPAA certified. But Andrew, do you want to speak a little bit more to that?
Sure, yeah. And we're going to have a session that's basically geared really around these guardrails and the compliance and security requirements that be a little bit more tailored for the technical folks and for risk managers. But in a nutshell, Bill hit the nail on the head that it really comes down to sort of what that partnership with the vendor looks like. And there's very real questions. Where does the PHI go? Where does the patient's information ever go? Is it only living on servers that you as a health center already have? Does it go one step removed from there to maybe a solution that is hosted by a close partner that runs in Microsoft Azure, for example, and Microsoft will sign a business associate agreement? Or does it go beyond that? And when we start working with, say, just platforms like OpenAI, and then you have individual end users that are deciding how they're going to interoperate with AI, this is sort of what we have traditionally called shadow IT. Now we call it, of course, shadow AI. And if you go and ask your staff how many people are using ChatGPT or using AI to some extent, if they're being honest, it is a very high number of them. How many of them are using it safely and securely? Gosh, I hope it's also a very high number of them. But there's training requirements around here. There's policies and procedure requirements around this. And there are technical guardrails that can be put in place as well. And so no matter which type of vendor that you're engaging with, so for example, with a vendor embedded AI solution that's coming from inside the EMR, well, as long as that data never leaves their data center. So if they're doing the AI work, what we call the inference work, but it uses specialized hardware, if they're doing that work in their data center, well, then in that regard, you've already engaged with them at that level. They already host all of your PHI and presumably, and you have to confirm this, of course, but they're applying all the same standards and security to data that you're now, submitting in an AI basis. When you start to partner with another vendor, somebody like RainTech, again, we're a business associate, just like Microsoft is. We have a very tight environment, which is completely isolated and segregated across every customer. We've been doing HIPAA for a very long time. We've been doing healthcare IT for 25 years, and we're not the only ones, of course. There's lots of other companies out there that do that, but not all of them do. And so there's a lot of people out there that are just talking AI, AI. And if they don't know what HIPAA is, if they don't know what 340B and FTCA and all these other regulatory requirements are in the healthcare space, then they're entirely likely to walk a health center maybe down, or any other healthcare provider for that matter, down the wrong path, because they might be sending that information out to a third party. It could be going to OpenAI or Anthropic or Google or whatever to do what I call that inference work, that specialized hardware. If they don't have that, they'll send it to someone else. And now the health center's compliance requirements, the boundary around which that they need to draw to ensure that that PHI is kept secure, has expanded, and that vendor may not even know it, and they may not even know it. And so the risk of a breach increases, and the risk of needing to notify a lot of patients that their information has been sent somewhere that they weren't aware of is also greatly increased.
Okay, Andrew, you have convinced me that I can trust you with my data. So if I am a health center, like it feels overwhelming. I mean, okay, how do I begin? What's a practical starting path for me if I'm like, okay, I would like to try this. Now what? Help me.
One, exactly that. First of all, deciding that it's time to get started. 3 years ago was way too early. 2 years ago was still quite a bit early. 6 months ago, yes. Starting about 6 months ago, the language models that are used for this automation and for AI to do the interpretive and sometimes decision-making work that it does have gotten much, much better. And so now is the time to say, okay, so what does this look like for us? And the best way to do that from where I'm sitting, the same reason why Bill often says that we're now partnered because we bring technology to the table, is that you need people who understand health center operations at a very, very deep level to help you start asking the questions around where is this applicable? Now, I can give you a very high level answer that just says anytime there's a function being performed for many hours a day or per month with one person sitting in front of one computer and never touching anything outside of that computer, sure, almost all of those could be sort of on the table to be considered. But not all of them are going to be very high value targets. And so you need to have an approach and a strategy that addresses the cultural part first and foremost. You have to make sure that everyone understands that this is to empower the health center, and it is not to reduce headcount at all. And again, this is certainly what I did in our company here at RainTech, and it's something that I very much recommend anyone looking to move toward adopting AI to do, is really confront that head on and let people know that this will not ever eliminate their job. It will change it, and hopefully for the much, much better. And it's going to make it much more satisfying and less tedious and less repetitive, and they're going to be able to work more directly with patients. And so there's a lot of pluses there. But first, you have to figure out what the landscape of opportunities look like. And so setting up internal working groups and committees for that are across the organization that come from all departments, I think is very helpful. I think engaging with groups like Bill and Thrive also help really drive high quality results out of that, because they're going to help kind of cut through some of the noise of what, somebody says, well, I think this one over here is really the best one. And then somebody in other departments like, well, but I think, this one here. And so understanding how to flatten those conversations down to say, what's really going to optimize our ability to execute on the mission of serving more patients, and then picking those ones and moving forward with them.
Yeah, and leadership sets the tone, and that not only includes the CEO and the C-suite, it includes the board. And I think health centers really need to take a look at board composition and look at, do I have somebody who has a decent understanding of this technology on our board, in order for the center to maintain their governance responsibilities. Successful centers, you start with a problem statement. Start with those kind of high value wins, but define the problem clearly, and then be transparent and let your staff know this is the problem we're addressing. Be open and honest with the assessment, the tweaks that are going to be made, because the first round isn't always going to be perfect, as we know with technology. A lot of times there's tweaks and adjustments. So those are the two things that I think are very important. The leading with your leadership, that's their role, and then having a clearly defined problem. We're not adopting AI to adopt AI because people are talking about AI. We're adopting AI to solve problems and to make things more efficient.
Okay, well, on that note, we're getting ready to close this out so we can take some questions. But if you could leave our audience with one mindset shift about AI's role in community health centers, what would it be, Bill?
So I'm looking at my screen because I actually have this written down. AI's real value in community health centers isn't automation. It's preservation. It's preservation of staff energy, preservation of financial stability, and most importantly, preservation of mission.
Andrew, do you have any closing words for us?
For sure, I'd say along the same lines is that AI has the ability to drastically reduce the amount of time it takes to perform a lot of functions. And there are a lot of vendors out there with AI-driven solutions. And it's very important to ask yourself the question, who's getting the bulk of that benefit? And, we talked about it a little bit last time. I'm sure we'll talk about it again. Billing companies that are still taking a percentage of claims even though they now have an AI-driven workflow, that's at least a very crucial point to pause and say, who are we really partnering with here? Because we're a nonprofit health center, and here's a billing company, and we've traditionally paid a percentage off the top, and that's sort of was fine when we had a one-to-one relationship with the volume of patients and encounters with the number of billers it took to do that. But now that that's been decoupled, I think that we need to encourage health centers to ask a little bit better questions, like why are we partnering with someone who's still taking a percentage off the top? And so, that and obviously moving into a realm where you're getting everyone excited about innovating with it and excited about how their job is going to get better and how they're going to be able to see or spend more time with patients on more edge cases and more complex issues, and having patients wait a lot less in order to get that kind of service. And so just getting people excited about it, we have to alleviate the fear around replacing humans. And so that's why I think the cultural part is always a good first step.
Great, thank you. Now I'm actually going to pivot to some of our questions, if that's okay. So we have a number of them in the chat box here. So is there any reason that a health center would not be ready to adopt AI? Gosh, culture comes to my mind and fear.
Yeah.
But that's
It's a process, not an event, right? We can't say, wake up today and say we're going to adopt AI. You need an AI strategy. You need to define, what is that human statement? What does this mean to our employees? What does it mean to our patients? So if you're not taking those steps, you're not ready to adopt AI.
Yeah, I would say if you're looking at headcount reduction would be another one. And that goes for any organization. It doesn't work. It just doesn't work. And even if a solution saves 50% of time, it's not saving 50% of employees' time. It's saving 50% of every employee's time that participates in that particular workflow. And that's what I think Wall Street is still getting their arms around, combined with obviously consumer-driven aspects of this that don't even really play a part here. And so I would say that that's kind of, one of the non-starters is because the AI will always be working alongside the human and is always optimized by the human. It's overseen by the human. The human is what understands the mission and what you guys are really doing there. And then all the idiosyncrasies and nuances of what actually are involved in that workflow. But otherwise, no, I would say that there's very little stopping anyone because the barriers to entry are very low, depending again on how you engage. It can cost little to nothing to get started and to get a custom solution developed so that you can start getting ROI literally out of the gate.
Okay, and we have another question that is somewhat similar in terms of what about like a smaller rural health center? Should we be focused on using AI for different workflows than metropolitan health centers that are often bigger? And should rural centers have the same expectations for AI integration as a bigger center?
I would say that I'll start with they should have the same expectation. And that expectation should be it's going to make things more efficient. It's going to better the patient experience, and it's going to improve our employee satisfaction, so to speak. There will be different workflows possibly in a rural health center. But that's it. I mean, with AI, you're trying to customize it to your particular need. We're trying to get away from the standardized EMR. Now we're going to the next level on what can we do to customize this to your particular center.
Yeah, so it's not just the nuances that are at a state level, but into the regional level too. So you look at things like payer mixes, and those are just very different, obviously, almost anywhere you go. And so different health centers might spend different amounts of time manually filling those gaps between what the EMR might to some degree automate and what has to be done manually by a human. And so certainly different health centers are going to find different opportunities and different low-hanging fruit based on how they've staffed and what their patient populations look like and how much time they're spending on those manual tasks, which is why I think a critical part of the strategy really is around taking a broad view to begin with and making sure that you've got representation across the board from your health center and that you're working with someone that can help really analyze in a sort of dispassionate way all of the different opportunities and where people are spending a lot of time. And sometimes that might really be boots on the ground. It's somebody like Bill or people on Bill's team who come in and they're working inside departments and watching what people are doing. We've been using actively production AI here in our company for at least 6 or 9 months now, I think, in a very mainstream way. Beyond that, in a little bit more of a narrow way, and it still occurs to us on almost a daily basis. That we're technologists, we're people that use this stuff all the time, and we'll have something new occur to us that we're like, oh, it could do this too, and it's like. Honestly, that's what this looks like. Anyone that's like, oh, I see the whole picture, the whole scope of everything that this stuff can do is looking too narrowly as far as I'm concerned. And so it really does take just exposure to an environment and seeing how people are doing things to then realize, oh, this is another opportunity for an AI-driven workflow.
Okay, we have a great question. It springs to mind for me. Health centers sometimes work together for group buying or as part of consortiums or maybe a PCA. And the question is it possible to get a custom solution that would work for multiple health centers?
100%. And that's exactly what we're hoping to do with the one that I was telling you about earlier today that we're sort of ready to go beta testing. The health center that we're working with, we met at a conference where I was delivering a workshop on AI, and they reached out to us afterwards and said, hey, we'd really like to look at some opportunities for this. And they're the ones that surfaced the workflow that they said, this is where we spend a lot of time and we think this might be available. And we literally connected them with our AI developer. Software engineer gets on the phone and does a screen share and watches what they're doing and listens to sort of the pain points. And like I said, in Virginia, we also fortunately were able to meet and connect with members of the PCA, VCHA there. And that's where we were able to learn that 31 health centers in Virginia all use the same EMR. And so guess what? They all have the same state level sort of Medicaid nuances and things like that as well. And so not just maybe, but absolutely yes. This is sort of one of these super powerful levers that, again, are available in nonprofit health that don't really exist out in the so-called business world because people aren't sharing these sorts of game-changing technologies. So when you combine that with the fact that we have a relatively short development life cycle to get into production, and that you can replicate and multiply this across as many health centers as have those same needs, absolutely. But again, it just requires some strategy. It requires relationships. Virginia is not the only state that we have close communications going on with at this level because it's the same thing that this person is asking is that can we buy once and replicate many times to benefit a lot of health centers? If you do that strategically with, say, a partner that is going to help leverage those economies of scale, yes. If all 1,400 health centers all go out and find and build their own custom solution, well, they're all going to get about that much benefit from it, but it's going to take a lot longer for that to get in place. You won't have the same level of consistency or compliance and things like that.
Okay, I have a tripartite question here. So this is a long one. So what kind of ongoing maintenance or upgrades are likely to be needed if we buy or build AI into something? What should we expect for ongoing costs compared to what we're used to now with our current data systems that don't use AI? And to what extent can it learn and improve on its own?
Wow, three really great questions and very very different questions. So the first one, the variability sort of in the environment, like what sort of ongoing care and feeding, I think is sort of how I got that in terms of what changes in the environment, what requires maintenance. So one very simple example is that when a software company like an EMR vendor changes their what we call API, or the application programming interface, but it's the sort of the way the computers talk to each other. If they change or they add some fields or they change the validation rules or something like that, then the underlying code that AI or agentic workflow is using has to be modified as well. So there's some regular block and tackling from a software engineering standpoint. When it comes to modifications to the models themselves, this is a lot less of a concern, to be honest with you. What we call frontier models are OpenAI's ChatGPT, Anthropic's Claude, Google Gemini, Perplexity. These so-called frontier models are getting larger and larger and larger. I really love the analogy I read on LinkedIn recently that said, do you really want your enterprise AI-driven workflow trained on 27 million tweets about Taylor Swift's wedding? And probably not. And so and this is again part of cutting through all the hype, the bubble, all that talk is again around consumer-driven demand. These platforms are trying to pivot into enterprise readiness, but again, they're trying to be one thing for all people, and that's just very challenging. What the future of enterprise and business AI really looks like are smaller custom models. Frankly, they're actually not gargantuan. They're not trained on tweets, for example.